So good afternoon, everybody. On behalf of team of AFPI Karnataka, I welcome all of you to this probably a very intriguing session, which is very important, I think, for all practicing physicians, not just family physicians, I feel, on interaction between drugs and also interaction between drugs and food. I guess one of the principles of medical ethics is non-maleficence, which is do no harm. So even if, and this era where people are doctor shopping, there are sometimes multiple prescriptions with multiple drugs of the same type or different type. And I feel as family physicians, it's very important that we integrate all this, understand about drug and drug food interaction, and give them a very comprehensive advice on what all could do good and what all could do harm. So apart from welcoming all the delegates, I have to give a special warm welcome to two distinguished experts in this field. One is Dr. Vidya, who's a very good friend of mine and my colleague at Philomena's. And second is Dr. Padma, who's I think needs probably no introduction. Soumya will do a detailed introduction though. So welcome to both the speakers, and I'll pass on the webinar to Dr. Soumya, who's the head of the scientific lead of AFPI Karnataka. So over to you, Soumya. I also request everybody to mute their mics so that there is no interruption in between, and the speakers are given a complete hand of the webinar. So over to you, Soumya.
Okay, thank you, Dr. Swapna. Today I'm blessed because the opening remark is made by one of my teachers, Dr. Swapna Bhaskar, who led me to the proper path of family medicine. And I have another beloved teacher, Dr. Padma. Dr. Padma is a very senior general practitioner, I would say, and one of the motivator for me, who also showed what a family practice is. Dr. Padma is a very senior clinical pharmacologist. She is a HOD of Saptagiri Medical College, and she has over 25 to 30 years of experience in teaching pharmacology. And I still remember my good old medical college days when most of my classmates used to say that second year subjects are very boring except for pharmacology, because Dr. Padma would never let us rest in peace. She is always interactive, on her toes, motivating us. What is the clinical relevance of the individual drugs in a doctor's life in day-to-day practice? That is how she's been very inspiring as a teacher for all of us and also for the generations to come. And when I said, please share me your CV, she refused. She said, I'm just one of you. So there is, so I would say that great teachers, leaders, great pathway, greater dimensions of our life. And I'm fortunate that Dr. Padma is speaking on a very important, pertinent topic, as Dr. Swapna Bhaskar has emphasized, that drug-drug interactions in our day-to-day practice. So welcome, Dr. Padma, officially, my guru and one of my motivator. And over to you, Dr. Padma, for a highly vibrant interaction. And then the second speaker for the day is Dr. Vidya. So we'll be introducing her after the first session. Thank you. Over to Dr. Padma.
Good afternoon to all of you. Am I audible?
Yes, ma'am. You are audible. Yes.
Yeah. Okay. Thanks for a nice introduction, which I have never heard till now. But I think that was too much also at the same time parallelly. So I hope I will do justice for whatever you have told just now. Okay. So my first slide.
Ma'am, I'll start sharing your slides.
Yeah, first slide.
Yes. I'll go on 1 minute. Can you see the slides?
Not yet.
Can we see?
Yes,
as Dr. Swapna told, drug interactions are a very, very important part in a doctor's life. Right from the day we come to second year. No, previous slide. I'll ask you to change the slide. Only then you change.
Okay, fine.
see, this word drug interaction is very important, right from second MBBS to till the day you brand yourself as a doctor. So that much importance is there, and especially in the past decade, it has become 100% relevant because of polypharmacy. This has made everybody to be alert while we are prescribing the drugs. And moreover, not only we prescribe the drugs, the patients also will say three common things. One is tiredness, where we write B complex. One is not getting sleep, we write some sedative hypnotics. And the third, usually they ask for one of the gastritis problem. So we either ask PPIs or H2 blockers. So these three are quite irrelevant to write from the doctor's point of view, but today, the problem is from both the sides. Patients do ask, and we have already segregated ourselves to family physicians, specialists, super specialists, and super specialists. So there is no interaction between the two, and the patient also does not show the prescription what is written by the other doctor. So this also contributes to drug interaction, and also writing irrelevant drugs, and also the combination might be irrelevant in some of the cases because we are familiar with too many brand names, though the guidelines say that we have to write the generic name. So these being the problems, and hence the drug interactions have become a major part in our patient history or whatever it is in the case sheet. And especially what I feel and I teach every student is, apart from asking their name, age, and interacting yourself along with present history, past history, directly go to drug history, because patient himself would have taken one, and secondly, he would have done some sort of window shopping, and third, he might have taken multiple drugs because one brand might not work in this fast world. So with this small introduction, I will go to some clinically relevant day-to-day practice in the era of polypharmacy, so that you will come to know why they should not be prescribed, and if at all they are prescribed, what precautions should be taken and to be told. Take 1 minute of the time to tell the patient, so that at least they don't go on a casualty basis to every hospital, so that even if they can't afford, they have to bear a 5-figure, which is very horrible in these days. Maybe some of us also will not be able to bear such a high cost. So depending on these, just spend 2 minutes with the patient, so that you are decreasing majority of the drug interactions. And also, please remember the dose that you are administering, so that no emergencies will occur and the person will bear a good quality of life, because our life is extended even till 3 figures, that is 100 years. So this being the problem, so please be aware of the polypharmacy, the drug interactions, which has to be added, which has not to be added, and 2 minutes time to the patient to tell them to take some preventions whenever they are taking these sorts of polypharmacy drugs. Next slide, please. Next slide. Next slide, Soumya, next slide. Okay, now I'll tell you some of the very commonly prescribed drugs and we encounter in our day-to-day practice. The first and the foremost, why these ACE inhibitors and ARBs have come to a greater one nowadays. See, actually these ACE inhibitors are prescribed mainly for hypertension. Though it has got several of the other uses, the most commonest one is ACE inhibitors or ARBs in case of hypertension. According to me, the hypertension is divided according to the age rather than the other causes. If the person is below 30, the sympathomimetics are more physiologically, and hence we prefer drugs like beta blockers. Between 40 to 60, we should be cardio-renoprotective apart from blood vessels. So we prefer ACE inhibitors or ARBs. Above 60, because of isolated systolic hypertension, we prefer calcium channel blockers, that too dihydropyridines. And after 80, most of the persons will be just sitting. Edema will be the main problem. And also the other things will not be at stake. So we usually start off with diuretics, that is hydrochlorothiazide, which has got dual mechanism of action, which will be more than sufficient in that particular age group. Now here, as we are using ACE inhibitors, not only in hypertension, but also in post-MI, CCF, diabetic nephropathy, today even in retinopathy, everywhere we are using ACE inhibitors, especially ramipril, and ARBs. In ARBs, we are using 2 or 3 varieties. And most of the times we use this rational combination of ACE inhibitors with hydrochlorothiazide. Previous slide. ACE inhibitors with hydrochlorothiazide or ACE inhibitors with furosemide, which are good combination because of 3 reasons. I'll come to that. And ACE inhibitors spironolactone is a very, very bad combination. So also ACE inhibitors, ARBs and spironolactone, where the only indication is in congestive cardiac failure. So the first 2 are very good combination because of 3 important points. Both of them belong to different groups of drugs. Both the ACE inhibitors have got 8 types of actions. That is, mainly they are mixed vasodilators. Preload, afterload is decreased. Cardiac work is decreased. Cardiac output is decreased. Systolic and diastolic BP is decreased. So the perfusion is increased, and indirectly the irrelevant heart rate is decreased. So all in all, it has got multiple mechanism of actions, and thereby lastly also decreases the apoptosis and also fibrosis and also remodeling. So because of all these things, what has happened, we are not seeing many of CCF cases also because of this total production, total actions. Now, this combination of hydrochlorothiazide with ACE, hydrochlorothiazide is a, as all of you know, it is a diuretic which acts on distal convoluted tubules. Initially, it causes diuresis, but on a long term, it causes vasodilatation. Today, the choice is chlorthalidone than hydrochlorothiazide, but both are equally effective according to my prescriptions. And so this combination, and also ACE inhibitors causes hyperkalemia, hydrochlorothiazide causes hypokalemia. So all in all, both are a good combination, and it is quite a rational combination. So also with ARBs, either telmisartan or olmesartan. The same thing holds good with ACE inhibitors and furosemide, but furosemide is very, very short acting. And if at all you give the dose at night, because ACE inhibitors and ARBs should be given at night, as RAS system is active during night. So actually you should start ACE inhibitors or ARBs at night. When the dose increases to a very high level, then you can switch it on, make it half off and switch it on to morning also. Otherwise, the best time to prescribe ACE inhibitors and ARBs is only at night because of the RAS being very active at night. ACE inhibitors and spironolactone and the other combination, as I told you, they all cause hyperkalemia. Hyperkalemia is not only bad for the kidneys, but also for the heart. Both hyper and hypo, both are emergency heart problems. So for this reason, and you have to keep on monitoring hyperkalemia, which can be monitored only through blood investigations. So to avoid such things, and also to give good quality of life, good patient confidence, not to see a doctor at least for 3 to 6 months, this combination, according to me, should be abandoned and should not be written at all. Though the last one, ACE inhibitors, ARBs, spironolactone, can be given during the period of CCF. Now we have got better drugs like Vimada and other things. The next thing what I want to tell you, especially when you write this combination of ACE inhibitors and hydrochlorothiazide, you should remember 3 most important adverse effects. One is dry brassy cough with ACE inhibitors, not with ARBs. Second is hyperkalemia. And the third one is hypotension. So all 3 you can give the remedies stating that the cough with ACE inhibitors will usually subside by about 3 months. Second, the hyperkalemia can be prevented, if you are writing all alone, can be prevented by not taking that big bananas. big bananas mainly, and also not prescribing K-Max syrup, which contains potassium. And in patients who are going to dialysis, do not give potassium binders. So these things should be kept alert, so that whenever we are prescribing only ACE inhibitors, these can be told to the patient, and also not to drink tender coconut water, which contains more potassium. If at all you are prescribing ARBs, nothing like that, because these ARBs, some of them do have vasodilatory activity also, and also they have antioxidant activities. Next slide, please. Next slide. Again, these are the combinations which are prescribed every now and then for resistant angina. And also, if the patient is not eligible for any sort of minor procedures or major procedures, we do prescribe these sorts of combination. Amongst them, the first one is totally irrelevant, because both of them cause bradycardia. Verapamil acts on SA node, AV node through L-type calcium channels, and hence cause bradycardia, whereas metoprolol acts through GPCR, beta-1 receptors, and hence cause bradycardia. So both of them put together may cause AV block, and so bradycardia at least is emergency, but AV block is, we just cannot. The time taken from home to the hospital itself is a major thing. So for that reason, please, even in the dreams, you are supposed to remember that verapamil and metoprolol is the worst combination what we can ever meet in our day-to-day life. And we see, even for refilling the prescriptions, please go through the drug histories, which I will give you an instance in the last slide. After the last slide, I'll just give you some 3 case scenarios where I have personally met, and that has happened to these patients, and they have got survived for next 5 to 6 years, not going to any major hospitals, tackling at home itself. So the second one is a good one, metoprolol with nitrates, especially isosorbide nitrates, which is given for chronic stable angina, or if the patient is also post-MI, etc. In such cases, we give this combination of metoprolol with nitrates or metoprolol with amlodipine. The most preferred is metoprolol with nitrate than metoprolol with amlodipine, because amlodipine causes reflex tachycardia, and also it can cause ankle edema. Whereas with nitrates, we have got the advantage that it also increases the blood flow, not only to the ischemic areas, but also to the non-ischemic areas. So, and this nitrates and this amlodipine causes tachycardias, which is counteracted by metoprolol, which causes the heart rate to be minimized, not below 60, please remember, but it will be maintaining between 60 to 100 when these combinations are given. And in resistant angina, we have also seen adding metoprolol, nitrates, and amlodipine because of 2 main reasons. Metoprolol will maintain the heart rate and decreases the cardiac work. Once it decreases the cardiac work, the diastole has more time, which causes coronary filling, whereas nitrates and amlodipine causes tachycardia, but nitrates decreases the preload, so that again cardiac work is enhanced, decreased, and also the cardiac load is also decreased, thereby the filling to the coronaries is increased, and so both ischemic and non-ischemic areas are perfused very nicely. Whereas with amlodipine, only the systole is decreased, the afterload is decreased, so reflex tachycardia is a concern, where when we combine, this may not be to a great extent because metoprolol will take care of it. Next slide, please. Now, the other most common one what we are encountering today is warfarin. Though many of them do not prescribe warfarin, as we have got nowadays NOAC, novel oral anticoagulants. Warfarin has got main problem of drug interactions. 1, both pharmacodynamic and pharmacokinetic. 2nd, we have to maintain the INR ratio. 3rd, we have to tell the patients that whenever they have to take any drug, please inform the doctor. These are the main problems which are met with warfarin. And one more problem is it can cause internal bleeding, especially in small intestines, where we cannot make out even with the greatest gadgets. And so patient might keep on going to hypotension even if you load them with umpty number of liquids also. So the patient might fall because of internal bleeding, especially in the small intestine. These are the four major things what we encounter in our clinical scenario. So the warfarin use has become quite less, but the cost is the hindering factor with NOACs. And in certain cases, people are still using warfarin, though in most of 80% of the cases, we are using novel oral anticoagulants. The most common ones what we see is with ciprofloxacin and macrolides like clarithromycin, because some of them, the clarithromycin might not be an enzyme inhibitor like erythromycin, but still has certain amount of this sort of enzyme inhibition. So because of this, here what happens, effect of INR is increased, and so we have to reduce the dose by 25 to 40%. So I don't think super specialists will have so much of time to do it. So better avoid both ciprofloxacin and macrolides as antibiotics whenever you come across that the person is on warfarin. The, the same thing holds good even with metronidazole as well as azole antifungals. More so concerned about azole antifungals because all antifungals should be given for a minimum period of 6 weeks to a maximum of 1 to 1.5 years. Though we may give certain of them weekly once also, but still we are seeing many of them going to various doctors as window shopping and encountering these pharmacokinetic drug interactions. And some of the older people might even prescribe ketoconazole, which is an enzyme inhibitor and also has so many other androgenic effects also. So because of all these problems, please be careful with the common antibiotics which are prescribed like fluoroquinolones or metronidazole, and also antifungals which are very commonly prescribed, where you are where the INR is increased and the dose of warfarin should be decreased to 25 to 40%. So rather than all these things, we can shift to various other antibiotics like beta-lactam antibiotics or cephalosporins, which is much more convenient. And also we have got good news about those things, not encountering major drug problems like what we see with other antibiotics. With rifampicin, all of you know that it is an enzyme inducer, a pharmacokinetic drug interaction. So this will enhance the metabolism of warfarin. So INR is decreased. So again, we have to increase the dose. By increasing, there might be even bleeding. So please be very careful with warfarin-like drugs, especially with antibiotics and rifampicin. Why I quoted rifampicin? I should have quoted with other antitubercular drugs also, because nowadays extra pulmonary tuberculosis is very rampant amongst doctors as well as not doctors also. And this is a very common drug which is prescribed at least for 6 to 9 months. So please be careful. And also along with this, the female, if at all it is in the female, they may be on oral contraceptives also. There also oral contraceptive efficacy will decrease. So person might become pregnant. On one hand, patient is becoming pregnant. Second, warfarin INR is increasing. Third, the antitubercular activity along with the other drugs might not be quite potent. So based on all this, we may encounter innumerable disease interactions. So for that reason, we have to be careful with three important things with warfarin. One is antibiotics, one is antitubercular drugs, especially warfarin, and the third one, I'll come to that now. Next slide, please. With NSAIDs. With NSAIDs, warfarin with aspirin, warfarin with clopidogrel. These are very, very common common combinations. What they prescribe, if at all they are prescribing with low dose of warfarin, at least manageable. But if they would have combined with clopidogrel 75 milligrams, then aspirin 150, warfarin 2 milligrams, then these are the problems. And with other NSAIDs, whenever they take, there is reversible actions of reversible antagonism with other NSAIDs, where diclofenac is almost all the NSAIDs are over-the-counter drugs, and many of them know all these things. And so what happens? There may be increased bleeding encountered with warfarin, and so the best advice, especially after 60 years, for any sorts of somatic pains, please remember, choose paracetamol even to the level of 1000 milligrams, or if the patient is unable to swallow or not likely to swallow, then you can use patches, diclofenac patches, which can work for 24 to 48 hours. There is a very small trickling which is not harmful as oral drugs or IV drugs to kidney as well as to the stomach. The other common drug interactions what we are encountering today is antibiotics with sucralfate. Now the days are almost gone in day-to-day practice as OPD practice. We commonly write sucralfate rather than common antacids or ranitidine or omeprazole or pantoprazole. This sucralfate is the one which is very, very commonly written, and also I think the foam agent and the common brand name is Gasvicon syrup. So these are the ones which are written very commonly. So these are ulcer protective agents where they form a gel, a foam-like thing on the surface of the mucosa of the stomach. So what happens? Antibiotics cannot be absorbed in the acidic media, especially drugs like ampicillin or any of the cephalosporin, and most of them are absorbed in acidic pH where this sucralfate will not allow the absorption, and so we have to be careful, and so we have to give at least 4 hours apart whenever we want to give antibiotics with sucralfate. Preferably choose antibiotics where we can give it as once daily dosage, like doxycycline or even azithromycin, where we can give it as once daily dosage. The last one where we are seeing very, very commonly is clopidogrel with aspirin, which I've already told you, but still I will tell you that this can be given both on acute basis as well as chronic basis. Chronic, clopidogrel 75, aspirin 75 or 150, and then the other way around is whenever we give in acute angina, where we give clopidogrel 300, as soluble aspirin 325, atorvastatin 80, and a small dose of beta blocker if the heart rate is more than 100, say about 12.5 to 25 milligrams. So here, in that case, whenever we add for clopidogrel and aspirin, in such cases, we have to send the patient to a tertiary hospital as quickly as possible. And whenever we are refilling prescriptions, don't use more than 75 milligrams of both. Otherwise, they will be bleeding, especially most often, very commonly, we encounter hematuria or hematemesis. And of course, melena, we can make out very well. Why I've written look for the brands. This also I will tell you in the 3 scenario cases which I have encountered personally in my practice. Nowadays, the common bookish thing is theophylline with ciprofloxacin, but nowadays we don't use theophylline to a very great detail. Commonly we use either doxycycline or acibrophyllin with N-acetylcysteine. In that case, you can use ciprofloxacin. Otherwise, please don't use theophylline with ciprofloxacin because of the cost, because theophylline and ciprofloxacin will have a very severe drug interaction, and so and also theophylline has got a very narrow margin of safety where it can go to even the poisoning cases, and instead of treating a bronchial asthma, we may land up in casualty treating some poisoning and drug interactions and drug induced toxicity rather than curing a disease. Next slide, please. Now I have given the last two slides are just the best practices in our practice, where we have seen the recommendations given, but nothing to beat our experience. Okay, but still we are supposed to follow, and the youngsters follow this very rigorously. They must have even by hearted also. So I have seen many of them doing these things also. So for that reason, what I feel is you just go through guidelines are only guidelines. Experience will make you a better person for prescribing than just remembering the guidelines. So here they say that prescribing conducting a drug regimen. Nobody has time to see drug history or previous prescription. So where this sentence holds good, I think you can imagine yourself. The second one is do not prescribe medications for patients receiving 5 or more. Whenever it is 5 or more, as all of you know, it is a polypharmacy, and continue medications indefinitely without comprehensive review, because we would have told for 5 days, they will continue continuously because they have to pay the charge, or they are quite used to that. So for that reason, they do not visit a doctor at all. So you please check the drug history and also dietary supplements. I think the next speaker will talk on the dietary supplements and determine whether the medications and the supplements should be discontinued or continued. We should see to it and tell them very strongly and document also, so that we can really tell them that we had 100% we had informed them, and it is their mistake that they have taken, which they should not have done. And so at least in the next visit, they will be very careful. The next slide, please. So what are the key recommendations? The first one is the identify potentially serious drug interactions. Secondly, anticoagulation clinics, or at least these family physicians should take drug history. 10 drugs, which is written very commonly, are they being continued or stopped or whatever it is should be seen. And reconciliation and review should be taken with every visit. Then warfarin dosage reduction by 30 to 50%, especially when added with other drugs, and more so compulsorily with amiodarone, because it has got 6 main side effects. And beta blockers should be tapered or discontinued before clonidine therapy, especially. And wherever combination is necessary, only you please put it. Don't put spironolactone, because we know about it very now and then. Reduce it as much as possible, and don't use it with potassium supplements. Now I'll come to these 3 clinical scenarios. The first one, as I told you, clopidogrel and aspirin. One of my patients, I just went for a home visit. So the patient was lying on the bed. He was also a stroke patient. So they had prescribed clopidogrel aspirin 1 brand, and then plain aspirin 150 milligrams other brand. So the patient was discharged from the hospital 48 hours back, and the next day patient started bleeding and had hematuria. So I was called right in the morning at 7 o'clock itself, where I saw him in this situation. So then what I did was, I just asked the further history and all, but nothing suited very well. Then I asked them to show the discharge summary, where they had written 2 different brand names of the same. So now you imagine clopidogrel 75 milligrams, aspirin 150, then aspirin 150. So was it needed? Was it there? So neither the duty doctor would have written the discharge summary, neither the duty doctor will see what they have written, because different brand names, and nor the super specialist will have time to check that 2 drugs of the same name is being written by different brand names. So just by stopping the drug, all the problems got resolved once for all. So just taking 1 minute for the drug history will stop so many problems. They were about to go back to the same hospital. They just waited for 24 hours. The problem subsided, and they were very happy with all these things. So many of us cannot afford also. So please keep this in mind, It is not like USMLE going to America and coming back, or UK or whatever it is. Still, Indians cannot afford. They will go with lot of loan and other things. So please keep these in mind. Take the drug history soon after the present history and the past history. Please take drug history so that these things are never missed. And so we are doing justice. Even if the patient does not follow, at least we don't have the guilt and we do it very properly. The next one,
Dr.
it came
Padma,
for
5 more
briefly.
minutes. Sorry to interrupt.
Yeah. 2 more minutes is enough. One more is metoprolol-induced bradycardia. See, they will write as a prophylactic treatment, both for hypertension, angina, post-MI, everything metoprolol is indicated. But most of them don't know the dose. Especially, I am not blaming only the outsiders, including Bangalore also. But most of the times we see non-Bangalorean doctors prescribing metoprolol till 200 milligrams also, apart from super specialists. So this 200 milligrams will make the patient go on to metoprolol-induced bradycardia into casualty. This I have seen personally, and I have been asking our house surgeons what type of casualty practice they see. Is it the poisonings what we used to see previously, or alcohol-induced traumas where they used to come for suturing, or any other poisoning, or any fighting? We used to see only such cases. But now we are seeing drug-induced casualties more so. So please, for metoprolol, especially metoprolol XL, please don't go beyond 25 to 50, maximum 50 milligrams. Though we have got with different companies, we have got till 200 milligrams, unless and until they have got a BP monitor or the pulse oximetry where they can monitor the pulse, and that should be between 60 to 100. And if at all a small difference is also there, they should come back and tell it completely. Otherwise, please don't prescribe more than 50 milligrams. It will take time to settle. That's all. A good talk for 2 minutes will build up the patient confidence to a maximum. The third and the last is prescribing insulin. Prescribing insulin has become very good nowadays. It's a very good drug where the HbA1c will drop down to the maximum. I agree with that. Every point I agree. And nowadays we have got the tendency to prescribe only the long-acting ones like glargine twice daily, where it will be more than sufficient and it will take care of all the peripheral organs also, and also to maintain the blood glucose level as well as HbA1c level. The only point I want to tell about insulin, especially the 30/70 and Act Rapid, is people will go to the major hospitals like St. John's, Ramaya, government hospital, everything. They would have prescribed insulin to the maximum depending on that day, but the person lives on the other end of Bangalore, or they would have been this side, but they live in the other side. Vice versa also holds good. And the patient takes the insulin very rigorously, but not the food. So because of this, they will go to hypoglycemia and also cardiac arrest, and also many of them have become vegetative. So they may be lying down for years together at home. Please, for heaven's sake, don't do this. If at all their house is at a very distant, then please give your numbers or teach them on a table how to record insulin and how to decrease or increase the dose of insulin. That is the sliding scale. People will definitely come back to us. We will never lose patience, but we have to say them how to titrate the dose so that they will, even if they die, there is no problem. But if they are vegetative, the family will have a total burden on them, and we don't know how many years that burden will be there. The attenders might even think every day and night, let the person die than living. So this is the state of affair, because when you go to home visits, you will come to know these states of affairs. And so for heaven's sake, I plead with all the persons who are talking, and for each one of them in your WhatsApp group, please message this so that it reaches umpty number of people, and you will save many people, and they can lead a normal quality of life with a small amount of work. so that they can lead life on their own and not depend on anybody. Thank you for giving me the opportunity, and special thanks to Dr. Soumya. Thank you very much.
Thank you, Dr. Padma ma'am, for that energized talk on very, very pertinent topic for family practice. Can we take a couple of questions, ma'am? Just 1 or 2
Yes.
minutes? Yeah. Dr. Suleiman wants to know the side effects of nitrates in combination with metoprolol.
Actually, the side effects are taken by metoprolol. See, metoprolol is a beta blocker. Beta 1 receptors in the heart, if it is blocked, the first thing is decrease in heart rate. The second one is decrease in cardiac work. With these two actions, what happens? Diastole time is more, coronary filling is more. Now, when you add with nitrates, what is happening? Nitrates are venous drugs. So they decrease the preload because of venodilatation and nitric oxide activity. So now what happens when they decrease the preload, the cardiac filling is decreased. Once the cardiac filling is decreased, cardiac work is decreased. Once the cardiac work is decreased, diastole time is increased. So coronary filling is increased. Because of vasodilatation, it causes decrease in blood pressure. Whenever there is decrease in blood pressure, automatically reflex tachycardia will take place. This reflex tachycardia is taken over by metoprolol. So this combination is good rather than being bad. So actually, the side effects is counteracted by adding metoprolol. So it is very safe to add rather than giving a single drug of isosorbate dinitrate 30 milligrams.
Okay. Ma'am, one more question. How do we treat this metoprolol-induced bradycardia in OPD practice?
First of all, prevention. 100% you have to have prevention. Whenever we write metoprolol XL, that is a common one what we write, metoprolol XL. So this XL should be started at a low dose. Then tell him to monitor the pulse. So once the pulse does not go below, according to me, 70 to be on the safer side, but we can take till 60. So once that is there, immediately stop the drug. Okay. Once you stop the drug, this will take care. But if it has gone below 40 and all, you have to send it to the higher centers.
Can we give atropine injection and then send the patient?
We can give, because it takes care only of the heart rate. It does not take care of anything. And atropine acts actually you should give isoprenoline.
Okay.
Because this is a beta blocker. No, you have to give a beta agonist, isoprenoline IV.
But isoprenoline IV, commonly we don't get it. Isoprenoline IV, commonly we do not, availability is very, very less.
That's why I'm asking. Atropine acts on the muscarinic receptors, M2. So beta 1 cannot be, or you have to give glucagon. Both have to be given parenterally.
Okay. Some centers, you know, where there are not even atropine, they just give at least 1 tablet of buscopan when there is a severe bradycardia, because that will also causes reflex tachycardia as one of them.
That is very mild, it is. You can try, but I don't have a solid evidence for that. But you can try. Many a times we can try. For example, I have treated patients with Globac for after ulcer. Okay, there is no evidence for that. But Globac contains so many things, including carbonyl iron, and that has resolved, apart from topical things, that has resolved after ulcers very nicely. So like that, buscopan, because it, as you told, it causes reflex tachycardia for a certain amount of time, that might be helpful.
Transient time, if you don't have anything. And there is another question. Is there any interaction between ondansetron and other drugs? Dr. Swapna wants to know.
Ondansetron should not be prescribed in very young patients or children because of QT prolongation. Apart from that, I don't find this one with ondansetron. As usual, I don't prefer these adverse effects of nausea, vomiting, diarrhea, allergy, and unless and until it is very severe, and constipation as adverse effects. Because whatever we take apart from non-drug also, these things are encountered. So these are not the things, but don't prescribe ondansetron in children below 10 years.
10 minutes. Okay. Dr. Sujit Mishra has a question. Is a combination of antibiotic in a single vial recommended?
What is that?
Is combination of antibiotics in a single vial recommended? Can we combine?
No. That will be pharmaceutical drug interactions.
Hmm.
See, unless and until we have got fixed dose combination like amoxicillin, clavulanic acid, piperacillin, tazobactam, then you can do it. Because if they are acidic and alkaline, there will be interaction in the syringe itself.
Correct. They are rational certified antibiotic combination, what you are stating. So if we combine
If they are rational and antibiotic fixed dose combinations, then only you can do it.
And one more issue is we do not know for which the patient might develop an adverse drug reaction in case.
Yeah, definitely. Yes, you are correct. Yes.
So
we will not come to know for which ADR, and the one which is not producing ADR, if we stop, then the patient will not be benefited also. No.
Correct. And unnecessary panic. So wiser to give individual antibiotics.
Yes.
Different vials.
And preferably as long as the patient can take orally. Please advise oral.
And also early switching from injectable to oral forms.
To oral. Or in other case of drugs like NSAIDs and other things, no, wherever you have got patches, you try to administer patches. So from IV to oral, from oral to patches.
Okay.
You are doing the best thing so that the patient will have a very good quality of life, confidence, and less cost.
Thank you, Dr. Padma, for this wonderful talk. Because of shortage of time, this is an elaborate topic. We have to move on. Thank you from Academy of Family Physicians of India and Karnataka chapter as well. Now over to Dr. Vidya. So Dr. Vidya, can you switch on your camera? We have hardly seen you. Dr. Vidya, it's my pleasure to introduce Dr. Vidya. She is a professor in Alamin College of Pharmacy, Bengaluru. She has PhD from Jawaharlal Nehru Technological University, Hyderabad. She has got her M Pharma from JSS College of Pharmacy, Uti, and B Pharma from Sri Ramakrishna College of Pharmacy, Coimbatore. She's a gold medalist in JSS College of Pharmacy for academic excellence in M Pharma. She's been awarded various awards like Annai Satyabama Award and Best Faculty Award at Alamin Institution. And she has over 20 articles in various international journals with good impact factor. And she's also an author of several books like Fundamentals of Clinical Research. And she's delivered talks in various seminars, conferences, and guest lectures. Welcome, Dr. Vidya. Over to you, Dr. Vidya, to enlighten us about food and drug interaction.
Thank you, ma'am. Good evening, one and all. Hope I'm audible.
Yes, you are, very much.
Yeah. So thank you for giving me the opportunity to enlighten on this drug-food interaction, which is a part which we never take it quite seriously. So I'll share my slides. One second. Whether my slides are viewable, ma'am?
Yes, it is. We can see your slides. Over to the slideshow, Dr. Vidya.
Yeah. So a question comes like, whether this food and drugs, are they all friends or are they all enemies? Isn't it or not? Because the concern what we give to drug and drug interaction, we don't practically give to the food, but wherein food has even the interaction that can lead to, fatality. So it's a time to, think over or to collect the history from a patient, like what is their food habit, how do they take, or it becomes like it has to be mandatory from practicing physicians to ask what is their food style, and to mandatory write it in the prescription, to enlighten whether it has to be in empty stomach or with food or without food. So what do a drug and food do when we put them together? So when we take either any drug or food, it can lead it to only three actions. Either the action of your drug will be increased, or the action of the drug will be decreased, or this combination may lead to a adverse effect, which is an unwanted effect for any one of us, which may lead to the reduced quality of life, or if it in a hospital setup, it may extend the stay of a patient, economic burden on the patient. So it is all the thing which we doesn't want, which could happen because of a simple food and drug interaction also. Coming to the concern, why does we need so much importance for a food? So actually food alters the bioavailability of the drug. That is the reason why we concentrate so much on the food. So it can alter the bioavailability of the drug by many ways, possibly by delaying the gastric emptying of the drug, by stimulating the bile flow, by changing the gastric pH, because all this will lead to what it is. It all will lead to the reduced absorption of the drug, so that the effectiveness take long time. So that is how the concern came for food. So if you take any drug or a food, if you concern in a fasting condition, if you take probably the pH average may be between 1 to 3, isn't it or not? So when you take a food inside, definitely the gastric pH will fluctuate from around, I can say, an average of 1.9 to 4.9 on an average. It depends obviously on the food what we take, but commonly from this gastric pH, your food can change the pH atmosphere or the environment to average of 2 to 5 pH level. So definitely what will happen when there is a change in pH happens, it alters the solubility character of the drug, dissolution character of the drug. So naturally what will happen? The absorption of the drug will be disturbed a lot. It is not only absorption, even metabolism, everything will be changed by a food. That is the reason why we have to concern about the food. Then it may increase the splanchnic blood flow. It can change the metabolism of a drug, or it can be a direct physical or chemical interaction between the drugs and the foods. The classic example is tetracycline with milk, which cause insoluble salt that cannot get absorbed. So drug will not get absorbed in the patient. So that is why we think about the food. The next another concern is, so if we take any literature, there are limited literatures actually available with food and drug compared to drug and drug. So if we take into food and drug interactions, sometimes there are a clear-cut information that the drugs have to be taken only in the empty stomach, but there are certain informations like either with food or empty stomach, or there are informations like it has to take only with the food. So that depends upon what food we take, what quantity we take, what temperature we take the food also matters. So your meal volume, your meal temperature also has a great effect towards your drug. So it can affect what? It can affect your drug transit time. It can affect your liminal dissolution. So obviously this all will affect your drug permeability. And when your drug permeability is affected, your systemic availability is going to change. So even a small meal or the temperature meal is a big concern when we take it with a drug. Coming to, so everybody concerns, I'm just moving little fast, I know, because I don't want to enhance the time too much also. So if we take like what kind of drugs to be taken with meal, or what are the drugs that doesn't require a meal? So for example, a drug which we know that it would cause nausea and vomiting, isn't it or not? That better can be taken with the food so that you can prevent this nausea and vomiting. Example like allopurinol. And if you take NSAIDs, NSAIDs gets better observed in the empty stomach, especially if you take like complicated molecules like ibuprofen. I mean, the PK is complicated. That's why I mean it as a complicated molecule. So if we take the drugs like NSAIDs, we most probably goes them with food or after food, because the reason is it will cause the GI irritation. But its absorption is better when we take it in the empty stomach. And there are certain drugs which will get better absorption only when we take it with food. Example like ritonavir and nitrofurantoin. And you can say that nitrofurantoin is a classic example to, we can prescribe with food or to be taken with food, because 40% the bioavailability of the drug will enhance or will be more when you take it with the food, rather you take it in an empty stomach. Phenytoin, propranolol, there are n number of drugs, antifungals, so which can be taken along with food or immediately after the food. So certain drugs we say do go for an empty stomach. So why do we? Because food may reduce the absorption of the drug, and that is the reason why we prefer these drugs to be taken only in the empty stomach. Very classic examples are all these things, like ACE inhibitors, thyroid drugs, alendronate. Alendronate is a very, very complex, drug. In fact, we will ask the patient to not even move an inch when you take you take this drug. You have to ask the patient to stand just erect for almost half an hour. Even your one move will alter the absorption. So these molecules are quite complicated molecules. So these drugs, there's no question of thinking them to take with food. Compulsory, it has to be, before or in the empty stomach only. So the empty stomach is, 1 hour before a meal or 2 hours after a meal. So that is what we call it as an empty stomach. So this is mandatory for all these drugs. Why? Because their absorption may be so better when you take them without any food. So when it comes to the regulatory agencies, so it is mandatory. Any pharma company who goes for a clinical trial studies, it is mandatory by either our DCGI or by our FDA that there should be the information on food and drug also. Does the drug for what you are applying, did you do a food drug study? Is it, there is a big branch for tasting of the food, everything. So it is such importance is given by the regulatory agencies also. So you have to have your food effect interaction, that is mandatory if you want to get approval for your drug to market in India or anywhere outside in India also. And in your patient information leaflets, it must be prescribed that how should the drug be taken. Should it be taken along with the drug, or it should be the food, it is an empty stomach, or with the food or after food, has to be compulsory informed in the patient information leaflets. So why I put it as regulation is such importance is given to the food when you take a drug. So the common reasons, as I was mentioning earlier, there are many foods that can delay the Tmax of a drug. The time to reach the maximum concentration. That is what we call it as a Tmax. So that can get extended because of the food. So the Cmax, that means the maximum steady state concentration that reaches in our blood. So either the foods can increase or decrease the Cmax of a drug. And these are few examples I have given, like for example, progesterone. So you have to take it with food because progesterone bioavailability is very good when we take it with food rather than taking it in an empty stomach. As I gave the example, nitrofurantoin earlier, the bioavailability of nitrofurantoin is awesome when we take with food, rather we taking it in the empty stomach. And alendronate, mycophenolic acid, that has to be taken only in the empty stomach, not at all with the food. And I've mentioned only the delayed release, not the common other one. So here are the very few common interactions with the drugs which we use more common in our daily to day life. So if you take grapefruit juice, always a question comes whether are we using a grapefruit juice often, in the sense, yes, we do. And it is since a seasonal, especially people residing in the hill areas, they often use this drug. And if we go to the rural areas, this is a drug which is used as a weight reducing agent commonly by many of the teenager women. So it is not something which can be waved off when we consider a food, because many times people think it's not an Indian food, or it is not much we are into, no, it is not so. Especially many of the people use this as a weight reducing agent. It is a beautiful weight reducing agent. So many people does use, they may not disclose this to us. So almost every drug I can say have a interaction with this grapefruit juice. It is a cytochrome 450 inhibitor. So any drug that gets metabolized by this will be affected by grapefruits. So their activity will be increased. So for example, like nifedipine, very common, statins. I can say one of the warning combination is this grapefruit juice with statin. So why is when people tend to reduce weight, one or the other way, probably their history might have statins, their medication history might have even the statins also. So erythromycin, warfarin, fexofenadine, few examples I have given here, but there are a handful of drugs that have a very potent, serious interaction with this grapefruit juice. So that leads to overdose and dose dependent adverse effects when we take with grapefruit juice. So the another thing is warfarin. As such itself a drug which has quite a lot of adverse effects, which has a very potent DDIs with other drugs, wherein it is the same with when it comes to the foods also. So when we take like cabbage, spinach, green leafy vegetables, which all have vitamin K content in it, and we take with warfarin, the action differs, isn't it, Anand? And this contrary happened during in the COVID also, because there was a concern about the coagulations, clottings during the COVID time. But then like foods given in hospitals where with a lot of green leafy vegetables, quite contraindications happens, but there is no documented evidence towards that, but it was occurring. Then, for example, glycofulvin with high fat meals, that is known to everyone because their absorption is very better when we take it with the high fat meals. A few other examples are monoamine oxidase inhibitors, very potent food interaction with all the fermented kind of foods, because let it be like a pickle or cheese, wine, especially we tell that all the milk products, they are not supposed to be taken with this, which could lead to a severe hypertensive crisis. It needs to be avoided. And then the very common drugs like ARBs and ACE inhibitors, not with potassium containing foods, that could lead to hyperkalemia. So iron, I no need to tell that it has a vast food drug interactions. So with either the dairy products, raw vegetables, whole grains, because this raw vegetables and whole grains not to be preferred with iron, because the heme absorption will be delayed when we eat it with raw vegetables. It is the same when we eat with the whole grains. It doesn't absorb the heme part of it. That is the reason why it should not be taken. Iron is always preferable to go ahead with the empty stomach, provided the patient can tolerate it. So that is the main concern, because iron we don't go for empty stomach, is major of the patients are not able to tolerate. But if the patient can tolerate, it is best to go ahead with the empty stomach for iron to enhance its absorption. Then for the next example is cetirizine, this one. It is with rock salt, because now it has become a trend that people use rock salt either for diet concern or what. But cetirizine has a potent food interaction with rock salt, because we know it is a sodium chloride. There are combinations with potassium chloride also in the rock salt. So cetirizine will interact with rock salt, that can cause you very severe ulcer. This says that lesser than 1 month is sufficient to cause a potent ulcer if we take these food and drug together. And expected mechanism is potassium chloride in rock salt is causing it. So the next is dexamethasone, which has a very potent interaction with pomegranate and grape juice. which will increase the activity of dexamethasone. So which needs to be asked from the patient about their food history also. Other few examples I have given. ORS not to be taken with fruit juices and salted drinks, as it will enhance the nausea and vomiting. And then with aspirin, garlic and ginger. Probably there may not be any person who don't consume garlic or ginger. And since it is a best home remedy for many of the things into the Indian population, so aspirin has a lot of bleeding risk with garlic and ginger, so which leads to be limited, not allowing the patient to take more amount of garlic or ginger. So heparin with the green tea, where the bleeding risk is more. Grapefruit and macrolides, again the activity will be enhanced. Alcohol, as it is very common, it can potentiate the actions of many drugs, as well as it is causing drowsiness and dizziness with patients who is taking any kind of drugs. But with OHA, we can observe a very sharp hypoglycemia, and the hypoglycemia occurs very sudden when it is taken with alcohol. We had a few patients in our hospital who comes with hypoglycemia, those who have taken with alcohol. So it is a very common thing that happens in the hospital setup. So this is very thing, tetracyclines, amoxicillin, erythromycin, almost like any food can, because of its food contents. We don't know what kind of food a patient take and what are all the minerals that are available. So definitely that will decrease the drugs absorption. Statins with grapefruit juice, yeah, worst combination, a contraindication I can say, because statin activity will be enhanced. So it is not only the concern of the efficacy of statin, we need to look it into the adverse effects of statins also. So the adverse effects will be promoted when these combinations are being used. Then phenobarbital with vitamin C, it has to be completely avoided because it will reduce the effect of phenobarbital, macrolides, then this one. Then comes very, very common drugs I have just picked up. Do we need to put them with or without food? See, when it comes into a question of with or without food, one thing has to be taken is with food also, what kind of food becomes a big concern. A high fat meal, a high protein meal, or a low carb meal, everything have a different kind of effect towards the drugs. So for example, diuretics, it is better to go ahead with the diuretics in an empty stomach, only with a glass of milk, rather than going with the food. So, and again, I want to highlight one thing is, it is better to consider as a individualization therapy rather than going it with a broad way. The reason is, for example, in an empty stomach, one patient may tolerate the drug. For example, in empty stomach, the other may not tolerate. So we may be in a position to go ahead with the food. So the only thing that is a concern is absorption of the drug will be greatly affected when we go ahead with the food. As I said before, because of the altered pH, the solubility and everything will change. So the net result is absorption will be delayed by the food. But if the patient is not tolerable, then comes the alternate. So it is always to better go for a individualization therapy rather than go into a broad way. So beta blockers are better to go with food. Nitrates are getting better absorbed without food. For example, ACE inhibitor, if you go with captopril, it is better to take captopril without food. But you take any other ACE inhibitors, you can go ahead with either food or without food. That doesn't have a greater clinical significance. Probably alteration in absorption may be there, but that may be minimal in such a way that there is no clinical significance to the effect. So that is what it means is. So if you take rosuvastatin is preferred in empty stomach, wherein all other kind of statins can be taken with or without food. So antihistamines are the same way. You can take it with or without food. There's no clinical significance. So wherever I highlight that with or without food, it doesn't mean that there is no interaction at all. There is interaction that doesn't have a clinical significance is what it is meant to be. So for example, antipyretics, a big concern because those are the drugs which moves so fast, but for fast relief, if you prescribe the drug, then it is better to go ahead with empty stomach, and we avoid it because of the gastric irritation. So we go ahead with food, but if you need a faster relief, depending upon the patient, it can even be okay with an empty stomach. NSAIDs with food, as I said, because to reduce the gastric irritation. Corticosteroids are better absorbed in presence of food. The bronchodilators, as I was mentioning, high fat meal may increase the level of theophylline, wherein high carbohydrate meal can reduce the effects. I do understand practically getting each and every patient's data towards their food and other intake may not be practically possible in a clinical setup. But one thing that has to be at least kept in mind is there are certain fatality kind of combinations that needs to be 100% avoided in even a clinical setup. So macrolides are very, very better absorbed in empty stomach, wherein their absorption decreases when we take it with the food. So albendazole is very good absorbed when we take with the food. So this antibiotics, which goes, like very common antibiotics and other drugs also have written, they have a very good absorption when we taken without food. Again, all antibiotics are not coming into that way, but I just have listed very few which we use commonly, like amphotericin, ciprofloxacin, levofloxacin. See, levofloxacin has a very, very complex PK. It's a very complex PK molecule. So its absorption is very good when we take with without the food. So with food, we have cefuroxime, cefapodoxime, sulfonamides, nitrofurantoins, all those things. Sulfonamides has a little contrary. Some articles, some literatures says that its absorption is better with food. Some says its absorption is better without food. Probably a minimal food intake would be sufficient when we go ahead with, sulfonamides. So levodopa absorption is very good without food. Methotrexate is good without food. Andensitron is, can be taken with or without food. There's no specificity because andensitron, as it has a potential DDI, it don't have a potential interaction with the food. There are no much specific foods we can say that has to be avoided with andensitron as we have like with the drugs. So either wood can be fine for andensitron. Nifedipine is preferred with food. Phenytoin better without food. If need with food, that has very, very less proteins because the proteins will reduce the absorptions of this phenytoin. So better, but if patient can't tolerable, we can tell them to avoid the proteins when we take the phenytoin. So, everyone are aware of these OHAs. Sulfonylureas are better without food. Metformin can be with or without food. And same with antacids that can be with or without food. It depends upon the patient's tolerability towards a drug. So this is what I have written is like how do the PK interaction happens, which as I mentioned before itself. So I have some 3 cases which we come across in our hospital that was related to drug food interaction. See, even being the clinical pharmacist, always like we also have a harsh kind of looking into a patient's case sheet with only drug interaction, wherein drug food interaction slips from our mind all the time. After this, when I was going, we thought like, yes, this is the area where we also little bit lack out and this needs to be taken care. So there are 3 cases I have put, which I have come across. So we had, this is a 4-year-old case of Philomena only. We had a 28-year female who skipped from the bike. She had swelling and she had severe pain with that. So the doctor put her with chimeral fort and other nutraceuticals. And even after 3 days, she was an inpatient. She was not an outpatient. She got admitted also here. because all the possibilities were ruled out during her admission. But she was keep on complaining that, her swelling and pain was not reduced. This is one case. If you could, get the answer for it, that is fine. There is another case where the patient is a atherosclerosis and he was on cilostazol and aspirin, but both were a past history for the patient. But one day the patient suddenly reported severe purpura, and purpura resolved immediately after we stopped with a particular food. So there is another woman who was on lansoprazole and warfarin, and she was admitted with metamesis. But metamesis is not because of warfarin, that I can confirm. So there is some food that involved in this hemoptysis. Okay, so these were the three cases which we have practically come across and been, taken into that. So there are vast area to cover with the drug and food interaction, but probably I have just concised it how much I could, do that. So these are the three cases, expecting, that someone could, give the answer for that. So that is what all your drug and food interactions are. So I feel to say that how much we concern towards the drug, kindly let us concern towards this the food also, which can even lead to a lot of fatality.
Dr. Vidya,
Thank you. Thank you very much.
yeah, thank you for that wonderful, exhaustive presentation. It was really enlightening talk about the various forms of interaction of common food, what we use. Can you put the slides of your questions so that you can discuss, and then we can take the questions if you don't mind?
Yeah. Is it viewable, ma'am?
No. Can you just get back to?
Yes. Yes. Now.
Yes. Yes, ma'am. Yes. So we have a couple of answers from the audience.
Yeah, I will open. I have.
Yeah, we have answers for question 2.
Question 2, grapefruit juice. Yes, it is correct.
Yeah.
Because grapefruit juice enhances the activity of the drug, thereby the patient developed the adverse drug reaction of purpura. So that was a correct answer.
Next one is
absolutely, I'm happy to see that the first one is also correct, high protein, because this patient this case was dealt by our department only. So when we were going, like we didn't have any clue like why wasn't not responding. And then like when we inquired about her food, she has the habit of eating this soya all the 3 times in her all 3 meals. So that was a reason why her chimeral fort didn't work out for her, especially. That is a correct answer. That's perfect.
Great, Dr. Shruti. Then
then
we have Dr. Pramod, who says thyroid medication and milk. I think
no, thyroid medications with anything is a big acceptable. No. No, a big no to thyroid medications except water.
Okay. Doctor, can you please go to case 3, because 1 and 2 we have solved it?
Yes, I'm going, ma'am. One second. I'm not able to.
Okay, can you just read out the question if you have a slide?
Yeah, 1 second. I don't know why it is stuck up. The patient was taking this one, what I can say, Warfarin.
Okay.
I think for that only we didn't
grape
get
juice
answer.
and Warfarin.
No. That was the case 3. Can you see that Warfarin was there and patient was on lansoprazole,
Okay.
but then admitted with hemoptysis? That was the question. So, any answers for that? That could be. So you won't believe the hemoptysis was due to garlic and ginger. So the patient used to take garlic by roasting the garlic daily. That is her regular, usual it seems. After she was started taking, because of non-pharmacological advice, someone told like ginger and garlic will reduce your cholesterol and all. So she has a habit of burning it in the stove, the garlic. It is not 1 pearl or 2 pearl, 10 to 20 pearls she used to take it since. So since this garlic and ginger is a very potent, antiplatelet action, she has led it with that. So that was a reason for it. Already ma'am answered, Sapna ma'am has answered ginger and garlic.
Yeah,
Okay.
even Dr.
So that was
Ramya ji had.
yeah, Dr. Ramya has also answered. So that, but we have like this numerous drug and food interactions. But I tried to wind up within your stipulated time, as I don't want to.
True. Dr.
extend
Ramya
the
also
talk.
wanted to know, we have a couple of questions, if you can take. Dr. Ramya wanted to know, what is the role of vitamin D? Is it to be given in empty stomach, or will it be better absorbed with milk?
A vitamin D can be taken. There's no concern big with vitamin D with the food or without food. That can be taken. It doesn't have even much interacts with the milk also. So that can be taken out. Vitamin D can be taken out with or without food, not a problem. It doesn't have any GI related effects also. So that can be taken.
Dr. Swapna
now
had a question on interaction of food with vitamins, especially B complex, which is, given left.
Yeah, I have not gone too into the nutrients because that is again a vast chapter, because majority of the minerals, vitamins, they all has a lot of interactions with many drugs. For example, like you take any antibiotic, we never has to be taken with a milk containing product, but we could see people, those who cannot take food, takes it with only a cup of coffee or cup of tea. Thus the calcium in it will interacts with the antibiotics. It will produce an insoluble complex. So the absorption of the drug will drastically reduce. Probably in the physician point of view, you feel that the effectiveness of the drug is very minimal. Probably you would go for a escalated other spectrum of drugs, but that could be because of a simple food interaction that has happened with the drug. So these vitamins and minerals we have even with the zinc. They all have an interaction with the antibiotics. So it is better, especially that milk containing products have to be completely avoided when we go with antibiotics because of their nutrients present in the food or in the milk.
Great session, Dr. Vidya. I think it is very enlightening for general practitioners like us to know how food interferes with each one of our lives in our day-to-day practice. I think each of you owe a separate session. I think next time probably the series on food drug or drug interactions can continue.
Only one thing I would add to say is we don't ask like normally with the patients, like how was their food intake, that is out of it's not our cup of tea, we have left it out. But like because ma'am knows, Sapna ma'am knows, we get people, those who come with lot and lot of alternative medicines, as well as like a lot of non-pharmacological. So even menthe is really awesome anti-hyperglycemic, but no patient will come and tell us, like then we will think the hypoglycemia is occurring because of our OHA. But probably morning 1 cup of menthe will be taken by the patient, and then he will go with either our sulfonylurea or with our biguanides, which won't be informed to you people when they come and meet you, and then you will be thinking that hypoglycemia is occurring because of your drug. But it might be a simple a juice, or it might be a very simple non-pharmacological food, a food or alternative medicine, which has a huge impact towards the choice of the drug, and especially a day where AMR is threatening us with cutthroat, these foods has to be taken into care. So
Definitely, definitely. Thank you.
Yeah.
Thank you
Soumya?
so much, Dr.
Soumya,
Vidya.
there is one more question.
Yeah.
Sorry to interrupt, Soumya. There's one more question. Any interaction between coconut water and any drugs?
Ma'am, coconut water has more
Hyperkalemia.
potassium. So hyperkalemia is very possible with coconut water. And coconut water is not also, like I can say that that is too, safe to take twice a day, thrice a day. Once a day of coconut water is fine. That too, not with the drugs, which can even cause hyperkalemia. Drugs which already cause hyperkalemia has to be completely avoided with coconut water, as this will cause a severe hyperkalemia.
Even in renal failure patients.
Yeah, ma'am. Yeah, ma'am. Yeah,
You have to be extra cautious. Thank you, Dr.
Yes,
Vidya. I
obvious.
think this session can go on, but because of shortage of time, we have
Yeah, I
to
don't want to take your
conclude the
more
session.
time.
Definitely, we need more inputs in our upcoming webinars. Thank
Yes.
you so much, Dr. Vidya. And
Thank you
over
so
to
much.
Dr. Ramakrishna Prasad, our Vice President of AFPI Karnataka chapter, for his concluding remarks. Dr. RK?
Thank you, Dr. Soumya. Truly a wonderful session. Thank you, Dr. Padma and Dr. Vidya. Dr. Vidya, I've had the pleasure of working very closely. And in fact,
Nice to see you,
two
sir.
of our clinical pharmacists, two of our clinical pharmacists are students of hers, Dr. Prathamesh and Dr. Farhan. I think this was a very valuable session, very practical session. And I particularly appreciated Dr. Padma, thank you for highlighting common scenarios that family physicians and general practitioners experience on a daily basis, and how to choose medications and what to be cognizant of. And Dr. Vidya, it was very, very valuable. And this is something often which we do not think about, to be honest. The food interactions with food and the medications we prescribe, many times we have deficiencies in knowledge, but also we don't think about it. So I think this was a very valuable reminder. I want to thank AFPI Karnataka for taking the lead and hosting such a valuable session. This session will be available as a video on YouTube, so you can access it and you can refresh your memory if you want to go back and look at some specific points. Thanks, of course, to our president, Dr. Swapna Bhaskar, and also to Dr. Soumya, our dynamic academic chief. And also thanks to everyone who attended this session in the afternoon. I saw that there was consistent attendance of close to 35 to 40 people. So really, thank you all. Wonderful session. Thank you very much.
Thank you, RK, and thank you, everyone. We just log out.